Hi guys, we have a case of small bowel obstruction now. I'm going to take this case as if someone comes into the ED with acute abdominal pain and I don't know what's going on. So again, the first thing I like to do is spend 15-20 seconds just scrolling through the CT to see what is the area in the abdomen pelvis that I want to focus most of my time on. So let's start with the lung basis. Again, I didn't see a big pneumothorax, pleural effusion, or consolidation, so I'll go down to the abdomen. Right when I go down, there is some ascites around the liver here. The liver itself looks okay. Let's go down to the gallbladder. The gallbladder looks okay. Let's look at the pancreas quickly. The pancreas looks okay. The thing that catches my eye is that the stomach is really distended in size. Kidney, I didn't see any hydronephrosis. I didn't see any big renal stones. And the stomach is dilated. As I go down, all these bowel loops are dilated as well. The number we usually say is that 369, so up to 3 centimeter dilatation of the small bowel is okay. 6 for colon and 9 centimeter for the cecum. Usually, I don't really measure bowel loops. Just grossly looking at it, this is dilated. Like if you have been looking at my other videos that I've been making and just compare the size of this bowel loop to bowel loop on the other CTs, this is that abnormally dilated bowel loops. And there is some fluid here tracking down the liver along the right paracolic gutter. Um, and other thing that catches my eye is that there's some suture material around this bowel loop, so that makes me think that this person had some kind of bowel surgery in the past. Let's go down. Here I'm looking at the sigmoid colon. The sigmoid colon is decompressed, and there is some ascites here too. So right now, just spending a little bit of time, I know that the primary pathology is probably in the bowel, and this, is concerning for bowel obstruction to me. So the next thing for me to do is to know why does this person have bowel obstruction. So common easy things I can exclude is sometimes people can have hernia causing the bowel obstruction. So let's just look through the abdominal wall to see if I see any hernia. There is small fat containing umbilical hernia, but there's no loop of bowel herniating out, so that's not the issue. The person does not have an inguinal hernia containing loop of bowel, or you can have obturator hernia, femoral hernia. So I didn't see any hernia. So now the other thing to do to find out where the obstruction is happening is to find some normal loop of bowel that's distal to the site of obstruction. So for example, let me just scroll down. So here the loop of bowel are normal, but I don't think it's the bowel proximal to it that's obstructed. So let's scroll down more. And right in this area, I do see some bowel loop that are normal in caliber. And here there's bowel loops that's abnormal in caliber. So if I can find, so the transition point, it makes me think that would be somewhere around here. The other thing that can also help is that now just by looking at it, I'm not 100% sure if that's a colon or a small bowel loop. If it's a colon, having feces in the colon is okay, but if it's a small bowel loop and there's feces in there, what it's telling me is that there's probably obstruction more downstream from it, so that there's stasis of the fecal material or enteric content in the small bowel, and that's why you have fecalization of the content. So let me just try to follow it. So I'm following it more proximally here and see proximally there's no fecalization, so it's just fluid. But as I go down more distally, you do see fecalization, and that could indicate that we're coming close to the point of obstruction. So let me go down more down here, and I do see that the ball from here continues out in this way, and right from this suture material proximal to the suture material, there's abnormal dilatation of the ball loops. Distal to the suture material, the ball is normal in caliber. So I'm guessing that this person probably had a small bowel resection with a reanastomosis, and there's obstruction at the site of anastomosis. That's my diagnosis. Now, the other thing that I do want to find out is that if there is bowel ischemia. So to look for bowel ischemia, what I do want to look is that if there's abnormal ball wall thickening or lack of contrast enhancement, and let's just look for that. So the bowel walls are enhancing pretty regularly. For example, like let's say even if I come here, which is normal bowel here, and if I compare the enhancement pattern here to, let's say, here, or even in these fecalized small bowel loops, they seem pretty uniform. So I'm just following, looking at the bowel wall. So the bowel wall enhancement is pretty normal. So no, I'm not convinced that there's ischemia. And here I'm getting close to normal bowel loops now. I mean, here it's still a little bit dilated, but from here it's normal in caliber. Now, why is the stomach so dilated? I don't know why the stomach is so dilated. But at least the proximal loop of jejunum seems okay. Somewhere around the distal jejunum and the ileum, they're abnormally dilated. The obstruction is at the site of this enterostomy at the bowel connection. The other thing let's try to look at is that if there's free air in the abdomen, which would be indicating of bowel perforation. So let's just go down and come back up. So usually I'm trying to look in the anterior abdominal wall just because air would be light and go up there. I didn't see anything. All this air that I'm seeing is still content inside the bowel. Now there's one there. Let me make sure that's in the bowel loop. Yeah, that's in the bowel loop. So that's okay. And anytime there's inflammation going on, I like to make sure that the vessels are patent. Again, our portal vein, left portal vein, right portal vein, main portal vein, splenic vein, superior mesenteric vein, or sorry, inferior mesenteric vein. There's the inferior mesenteric vein is coming off of the splenic vein. And I would follow them a little bit more distally to make sure that they're okay. So the branches of the superior mesenteric vein are widely patent. So at this point, I'll just follow. So the main problem I identified so far is small bowel obstruction with transition point at the interostomy in the right lower quadrant. And here we can see too, it would be right there. And at this point, I'll just follow my source pattern just to make sure there's no incidental finding. Liver, gallbladder, spleen, pancreas, adrenal, kidney. There's a tiny, I would probably call it an angiomyolipoma just because it is fat in density, and a renal lesion that's small with fat density, we can safely call it angiomyolipoma. Now there are these two small things. Now we call it sister angiomyolipoma. I didn't think we can accurately tell what it is. It looks like angiomyolipoma, but I'm not confident. And there's one right here too. And then I'll follow the ureters down on both sides, and then follow my colon up. There's my descending colon right here, pretty decompressed. My transverse colon is here, 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 coming back. This is my descending colon. This is my terminal ileum going into the cecum. And let's see if I find the appendix. Now, finding appendix can be hard. I'm not going to spend a bunch of time now trying to find appendix, so I'll look at that, and then I'll look at the aorta, IVC, looking for lymph node. There's a few prominent lymph nodes around here, here. They're probably just reactive. They don't look too abnormal to me. A few prominent inguinal lymph nodes on both sides. And then I'll look through the bones and look through the lung bases carefully to make sure that there's no lung nodules. Look at the heart pericardium. Thanks for watching the video.